Hey podcast listeners, Jim Sigler here. It makes a lot of sense to go to a hospital when you're sick. You're ill and you need a team of doctors and nurses to make you better. I know I sound like an idiot when I'm saying this, but going to a hospital is not always the best thing. The hospital is like a never-ending house party for infectious microbes. Drug-resistant disease-causing bacteria and viruses breed on its repeatedly touched furniture surfaces. And as an inpatient, you're confined to a bed, and often you feel too ill to even move. But laying down day after day is not good for your body. Lack of calf muscle contraction from resting in bed can create clots in your legs, resulting in pulmonary embolism. You risk skin breakdown and decubitus ulcers, and you even lose muscle mass at a rate of maybe 3 to 5% per day. Then there's the annoying stuff, like being woken at 4 a.m. to phlebotomists, whose unfortunate job is to wake up sick patients in the middle of the night and stick them with needles. And people are constantly bothering you. Nurses checking your blood pressure and heart rate, consultants repeating questions that you've already answered a dozen times. Not to mention, you're completely surrounded by other sick people. Don't misunderstand me. If you're sick and if you need medical attention, seek medical attention. Go to a hospital. But there's a gross public misunderstanding that the hospital is the ideal place to be when you're sick. Of the risks and complications of hospitalization, particularly among the elderly, one is delirium. It's one of the most common reasons for a neurology or psychiatry consultation in most institutions, and it's unsurprisingly a major contributor of morbidity and even mortality. And that's what we'll be talking about on Brainwaves this week. But first, a quick word from one of our sponsors. You're probably thinking to yourself, what in the world am I going to snack on? Well, I'll tell you what. Go to our website at brainwaves.me and check out some of the links to NatureBox. Whether you're into dried pineapple rings or white cheddar caramel popcorn, you're bound to find something tasty, healthy, and affordable. Your first 3 snacks are free if you use the links from our blog. NatureBox. Eat well, live better. This week on the Brainwaves podcast, I got to talk with an old friend who's a psychiatry resident at Penn.
My name is Ayyappan Venkatraman, and I'm a second-year psychiatry resident at the University of Pennsylvania.
We worked together on a neurology consult service a few years back, and he basically taught me everything I know about audio recording.
I love that this is recording. I guess the only thing
Anyway, I asked Ayyappan to share some of his experience with me this week on what was probably bread and butter inpatient psychiatry to him, like altered mental status is bread and butter inpatient neurology to me. And hopefully, in navigating through a real case I had, we'll hit most of the high points for this week's topic. Well, here we go. Bear with me here. The patient we're going to talk about is a 51-year-old woman who was brought into the ED by her husband after she was found down. She was previously healthy and she was presumed to be neurologically intact prior to this event. Neurology was consulted because her history was suspicious for the first seizure of life. She had incontinence of urine and there was evidence of muscle breakdown with a serum CK in the 10,000 range. But no one had observed any witnessed convulsions or loss of consciousness. Her vital signs on arrival to the ED were mostly normal, blood pressure in the 150s over 90s. Her exam was impressive on account of her lethargy, and she required constant stimulation to maintain attention. She was nonverbal and did not grunt or moan. There was no phonation, and she was slow to follow commands, but was strong in all her extremities, and otherwise there was nothing focal about her exam. She appeared to have a toxic or a metabolic encephalopathy, or she could have even been postictal from a seizure. The ED team ruled out a myocardial infarction with serial troponins and EKGs, so our neurology team was ultimately consulted for could this be a seizure. We obtained a head CT to rule out hemorrhage, which it did. We got a routine EEG, which didn't show any focal epileptiform abnormalities, and then we got an MRI. The brain MRI was performed with and without contrast, and it showed no mass lesions, but there were some patchy areas of restricted diffusion in the bilateral precentral gyri, which may have made sense in the setting of a seizure. Repeat MRI in a week showed normalization of these abnormalities, and so we assumed that they were all related to the seizure activity. We treated her empirically with Keppra based on her body weight and renal function. So let's just fast forward through her hospital course. She had labs to rule out toxic and metabolic encephalopathy, which were normal. A urine drug screen confirmed there was cocaine, and there was even a quantitative UDS sent on day 4 because she had been altered following a visit with her boyfriend, and there was suspicion of recent intoxication. The UDS was able to confirm a higher percentage of cocaine metabolites in her system than when she had initially arrived. Eventually, she had improved enough to be transferred out of the neuro ICU and without any recurrence of her seizures. But her speech never fully recovered, and she remained slow, inattentive, and lethargic. So, that's a long history. It's been about a week since she's arrived. She's had no structural lesion in her brain, no EEG evidence of seizures, and her labs are only notable for recent cocaine use. Ayyappan, can you walk me through what you think's going on?
So at this point, we still have altered mental status without any clear etiology. The only real thing we can point to is her cocaine use. This could plausibly be explained by acute cocaine withdrawal. That could be explaining her slowness in attention. We know that excessive cocaine use can encourage levels of hyperactivity and then hyperthermia or even rhabdomyolysis, which is evidenced by her elevated CK on presentation, which then combined with global toxic metabolic effects of cocaine use and whatever else it may be cut with. In addition to toxicity from substances such as synthetic cannabinoids that don't appear on most drug screens, maybe all of these things put together could plausibly explain bad general brain functioning and could explain what's going on right now.
So the psychiatry team actually did see her and they recommended a more thorough psychiatric assessment. Unfortunately, she remained nonverbal and she refused to write, so most of her exam was pretty limited. She could nod for most yes-no questions, and she followed some commands with hands and fingers, but she didn't do much else other than that. She did appear drowsy most of the time, and she was inattentive. She made eye contact with her provider, but would look away. She didn't appear to be responding to any internal stimuli. There's nothing concerning in that regard. Rather, she appeared disinterested and maybe just had a flat affect. When you asked her if she felt like something was wrong with her, just to assess for her insight, she would kind of shrug her shoulders. She didn't seem to really grasp what was going on. Given her lack of improvement with, more conservative measures for possible delirium, treating with fluids, vitamin and electrolyte replacement, and maintaining her normal vital signs, the psych team eventually recommended initiation of an antipsychotic for a possible hypoactive delirium. But there are so many to choose from. So let's say that you were her treating physician, Ayyappan. What antipsychotic would you choose?
So I'll begin by addressing delirium from a sort of conceptual standpoint and then getting more into the idea of hypoactive delirium and what medications could be useful. So in general, delirium is pretty accurately described as acute brain failure. It's an acute confusional state characterized by waxing and waning alertness and consciousness and attention. We should remember that delirium describes derangements in brain function that are related to some other underlying cause, and it isn't a disease process in and of itself. And generally, delirium can be classified into two subtypes, hyperactive and hypoactive. Generally, manic and psychotic symptoms such as hallucinations and delusions map well to hyperactive delirium, and depressive symptoms such as inattentiveness, disinterest correspond to hypoactive delirium. Both subtypes can present in response to acute medical illness or acute alterations in homeostasis. When we talk about the pathology of delirium, the earliest seminal EEG studies of delirium describe global cortical dysfunction with slowing of dominant posterior alpha rhythm and the appearance of abnormal slow wave activity in general. On a neurotransmitter level, we often attribute both hyperactive and hypoactive delirium symptoms to derangements in the brain's acetylcholine and dopaminergic systems.
When Dr. Venkatraman refers to the dopaminergic systems in general, he's more specifically referring to the nigrostriatal pathway.
Deals with movement.
And is the pathway that breaks down in Parkinson's disease. The tuberoinfundibular pathway.
Regulates prolactin secretion through tonic dopamine signaling.
And the mesolimbic and mesocortical pathways.
The mesolimbic pathway is associated with pleasurable sensations and the so-called positive symptoms of psychosis, which are hallucinations and delusions, and the mesocortical pathway is essential for cognition and executive functioning.
With derangement in the mesocortical pathway thought to be responsible for the negative symptoms of schizophrenia, such as inattentiveness, disinterest, and a flattened affect.
With hyperactive delirium being caused by too much dopamine in the mesolimbic pathway and hypoactive delirium being caused by too little dopamine in the mesocortical pathway. But that's probably a gross oversimplification.
While each of these neural circuits have their own unique roles, they each rely on the same principal monoamine for signaling, dopamine. Their different receptors and the different neural connections they have, as we'll discuss, are what are responsible for their unique functions and the unique symptoms associated with their dysfunction.
And we can't talk about dopamine in the brain without talking about antipsychotics. In general, the mechanism of action of antipsychotics is to block dopamine, and in schizophrenia, they're used particularly to reduce dopaminergic activity in the mesolimbic pathway and to reduce positive symptoms. However, it's extremely important to recognize that there's two broad classes of antipsychotics.
First generation,
or conventional antipsychotics.
These would be haloperidol, chlorpromazine, fluphenazine, and thorazine. And then we have the second generation class of dopamine antagonists, otherwise known as
atypical antipsychotics.
Drugs like olanzapine, quetiapine, lurasidone.
So antipsychotics were actually first discovered in the 1950s with chlorpromazine or thorazine, a drug with antihistamine properties that were serendipitously discovered to have antipsychotic effects, seen to be secondary to blockade of the D2 receptor. Drugs discovered after thorazine, such as Prolixin or Haldol, also have primary effect at the D2 receptor and are known as first-generation antipsychotics. Prominent side effects of the first-generation antipsychotics include extrapyramidal symptoms such as acute dystonias and Parkinsonism, which is attributable to D2 blockade in the nigrostriatal system. And there's also other side effects such as galactorrhea or amenorrhea from unopposed prolactin secretion when you block the tonic dopamine. It's important to note that first-generation antipsychotics can have strong intrinsic anticholinergic activity that varies by what drug you're talking about. Blocking acetylcholine in the nigrostriatal system helps mitigate extrapyramidal symptoms because it limits excessive acetylcholine activity that comes from dopamine blockade.
I'll admit that I did get a little lost here when Ayyappan started to dive into the non-selective, non-dopaminergic activity of antipsychotics. But to reiterate, one major pharmacologic consequence of first-generation antipsychotics is that antagonism of D2 receptors in the nigrostriatal pathway inadvertently increases acetylcholine release. However, first-generation antipsychotics can also antagonize muscarinic acetylcholine receptors throughout the circuitry, thereby inhibiting acetylcholine signaling, causing symptoms like dry mouth, constipation, and urinary retention. And also, importantly, this interference with acetylcholine signaling can paradoxically worsen delirium.
At baseline, dopamine in the nigrostriatal system tamps down acetylcholine, so when you block dopamine with an antipsychotic, acetylcholine levels rise. So, giving an anticholinergic, such as benztropine, or a first-generation antipsychotic with high anticholinergic activity, blocks that excessive acetylcholine and can help reduce extrapyramidal symptoms.
Kind of complex to wrap your head around, but this neuropharmacology has enormous clinical implications for your patients, and potentially innumerable uses.
And that's why people get confused when they see a patient with bipolar disorder and they're on an antipsychotic. Or you have patients who are like, why am I on an antipsychotic? And it's not an antipsychotic, it's actually a mood stabilizer, or it's doing 7 different things, and it's, I don't know.
Things like antagonizing one of several different serotonergic 5-HT2 receptors, which is what the atypical antipsychotics also do.
Like, through this convoluted pathway of like glutamate stimulating a GABA receptor, stimulating a downstream dopamine receptor. This kind of like...
It's a chemical neuropharmacologic nightmare. Makes you miss your classes in med school when you learned about how metoprolol was a selective beta-1 antagonist, or that Benadryl is a straightforward antihistamine, blocking the H1 receptor. But let's just restate the important relationships between dopamine and acetylcholine one more time for the purposes of antipsychotic effects, because that's worth knowing.
The first-generation antipsychotics that have more D2 blocking ability tend to have less anticholinergic/antihistaminergic activity with more EPS, and these are known as the high-potency antipsychotics. And drugs that have less D2 blocking ability with more anticholinergic/antihistaminergic activity are known as low-potency first-generation antipsychotics.
In the wake of these irritative and sometimes permanent side effects of first-generation antipsychotics, a second generation of dopaminergic antagonists was introduced, the atypical antipsychotics.
These drugs are crucially different from first-generation antipsychotics in that they not only have D2 blocking ability, but they also block 5-HT2. 5-HT2 antagonism mitigates EPS by encouraging downstream release of dopamine in the nigrostriatal pathway.
So more available dopamine in the striatum, fewer extrapyramidal side effects, which made them atypical compared to the first generation of antipsychotics.
That's how they got that name.
But this doesn't mean that they were any more selective for D2 receptors.
Really, labeling atypical antipsychotics as antipsychotics is kind of a misnomer. Across the different drugs, they not only may block D2, they may also have strong antihistaminergic, anticholinergic effects, as well as binding to all 7 of the serotonin receptors, alpha and beta receptors, and other dopamine receptors. And this helps explain how various atypical antipsychotics can be very effective in treating other aspects of mental illness, such as mood stabilization, augmentation of antidepressants.
And it's for these reasons that second-generation antipsychotics and even the first-generation antipsychotics can be practically personalized.
For example, clozapine, one of the most effective antipsychotics in schizophrenia generally, actually has very little comparative dopamine blocking ability. And this indicates that its efficacy could lie in just the way it pushes all these other levers in the brain. Getting back to delirium, antipsychotics are employed in hyperactive delirium to help manage behavior and reduce positive symptoms, aka the mesolimbic pathway, to help keep patients safe while their underlying cause of delirium is being treated. However, there are studies that have shown that antipsychotics may have a role in hypoactive delirium as well. Important considerations to think about when starting antipsychotics include routine EKG monitoring for prolonged QTC, as QTC over 500 is associated with the development of torsades de pointe.
In someone with a prolonged QTC, if any antipsychotic is needed, you might prefer an agent like aripiprazole, which is arguably a third-generation antipsychotic drug. Or you could even select something in an entirely different class of medications, maybe even valproic acid.
And we would also want to consider that antipsychotics with more anticholinergic activity could actually worsen delirious states.
Clozapine would be one such drug with potent anticholinergic properties, whereas risperidone has very minimal anticholinergic effects.
On the other hand, antipsychotics that have greater antihistaminergic activity and promote sleep could be useful in resetting altered sleep-wake cycles.
Quetiapine or olanzapine are 2 drugs you might turn to here.
All that being said, Haldol,
aka vitamin H,
which is a very good go-to medication in cases where delirium is suspected.
Is that what you would have started this patient on? Finally, we are making our way back to the clinical case.
Yeah.
Remember the 51-year-old woman with acute hypoactive delirium?
So this case in particular is somewhat confusing, and there's a lot of different competing factors going on right now. On the one hand, hypoactive delirium is not very well studied, and there's not a lot of evidence about it. And it makes sense. Hyperactive patients in the hospital are going to be picked out and are much easier to identify. If a patient's hallucinating that there's birds flying in the room and they're yelling and requiring restraints, it's easy to say that this patient's delirious. And then on the other hand, if you have a patient who is quiet and doesn't really make a lot of fuss, it's just laying back, it's a little bit elderly, you may not really be so quick to identify hypoactive delirium, and you may just be like, oh, this patient's great. They're the easiest patient on my list. So maybe due to that.
But just because these hypoactive patients are less a threat to their own healthcare compared to hyperactively delirious patients, they aren't as obstructive to receiving medications, they're not lashing out violently, and so on. It doesn't mean that they have a good overall prognosis. Ayyappan and I talked about this a bit, and studies have shown that patients with hypoactive delirium have a greater number of comorbidities and longer hospital stays than patients who have hyperactive delirium.
The other problem that you do run into with antipsychotics in a case of hypoactive delirium, however, still has to do with those same dopaminergic pathways, because we know that blockade of the D2 receptors with drugs like haloperidol or other high-potency antipsychotics is that they have the potential to slow cognitive and executive functioning in the mesocortical pathway. So we're trying to take advantage of blockade of the mesolimbic pathway, but these drugs aren't discriminating, and they're also blocking the same parts of your brain that you need for executive functioning. And this is also evidenced by how the negative symptoms of schizophrenia, such as disinterest, flat affect, executive dysfunction, all these things that seem to resemble hypoactive delirium, generally worsen with high-potency antipsychotic treatment.
So maybe in these circumstances, you'd avoid antipsychotics altogether and try some other class of drug for a hypoactive delirium.
There is evidence, on the other hand, that stimulants like methylphenidate that increase dopamine can also be effective in mitigating the symptoms of hypoactive delirium. However, you run into some problems. Like, for example, in this patient, the difficulty with starting a stimulant may be you could run the risk of causing positive symptoms and worsening a delirious state with too much dopamine in the mesolimbic pathway. And the other thing for this patient in particular, the only thing that we really know about her is that she's had a lot of trouble with a particularly powerful dopamine reuptake inhibitor, cocaine, so we probably want to avoid more stimulants. So we're really in a tough situation here, and honestly, these pathways in question are so complicated that we're really just taking a blind shot at trying to restore dopamine homeostasis however we can, while the real underlying cause gets identified and treated.
Kind of a theme throughout much of medicine. Pass the time with symptomatic treatment or palliative measures while you address the principal problem. But for this patient, it's not entirely clear what the principal problem is. With her pattern of restricted diffusion on MRI, could she have had a seizure and now she has a post-ictal hypoactive psychosis? Could she be withdrawing from cocaine or some other substance intoxication? Does she have an underlying neuropsychiatric condition that has not even been diagnosed yet? It was all very confusing to me.
So I'm confused too.
Okay.
I mean, and in this case, if we're boiling it down, we have a patient who appears delirious, regardless of hyperactive versus hypoactive. And the medication options we have are somewhat limited. We have Haldol, which is very well studied in delirium in general. And the other option that we could possibly consider for hypoactive delirium, stimulants, wouldn't really be appropriate here. So it really is just kind of a blind shot at using some medication in this pathway system to help regulate her dopamine pathways and get it back to some level of functioning.
Like a trial and error.
That's how it seems to be used in this scenario.
So in the spirit of that, and after ongoing multidisciplinary discussions, the patient was given a trial of haloperidol. She continued to haloperidol and was ultimately discharged to an inpatient rehab facility to work on her speech and her generalized weakness from her hospitalization. So what kind of recovery might we expect with her course of haloperidol, and what should her treatment team be looking for as she continues with this therapy?
So I can definitely see how frustrating this case is, and how at a certain point, with all of this sort of diagnostic confusion and the patient's behavior not really fitting into any one clear syndrome, how we don't really have a lot of direction. I could definitely see how Haldol could be tried in this situation. Some of the things that you mentioned certainly make this concerning for a functional etiology rather than ongoing hypoactive delirium without a clear cause or some other neurologic disorder that we aren't thinking about. If this patient were continued on Haldol, the longest term risk of prolonged antipsychotic use is tardive dyskinesia, which is a movement disorder results from hypersensitivity of nigrostriatal dopamine receptors in the setting of chronic dopamine blockade.
And if you haven't seen someone with tardive dyskinesia, the symptoms are pretty classic. And before we recognize these symptoms could become permanent, as many as 1 in 4 patients on chronic D2 blockers would manifest with these irregular motor patterns: facial grimacing, tongue writhing, lip smacking, choreiform or jerky arm movements. Nowadays, you should be seeing less of it because we try to transition patients to the atypical antipsychotics whenever possible.
However, I doubt that this patient would be continued on Haldol for that long unless someone really drops the ball somewhere down the line. If a patient were continued on an atypical antipsychotic, let's say instead of Haldol she were started on risperidone or olanzapine, a major consideration to think about long term would be metabolic monitoring of weight, hemoglobin A1C, and lipids, as many atypical antipsychotics have a strong association with metabolic dysfunction.
Olanzapine just happens to be one of the worst.
And we actually still don't really know why.
But quetiapine, or Seroquel, also elevates your triglycerides over the long term, and risperidone is known to cause weight gain as well.
As far as recovery and other long-term issues, delirium is associated with cognitive impairment. A New England Journal of Medicine study of postoperative delirium found short-term impairment in cognition that only very slowly improves, as formerly delirious patients were significantly less likely to return to baseline cognition after 6 months than those without delirium. Delirium was once thought of as a transitory disorder, but it in fact has prolonged cognitive consequences that could impair treatment of other coexisting conditions. So early intervention and further treatment may be necessary for those patients who are delirious, and it should influence just how intensive your care might be for other conditions that you're treating. And it really emphasizes that you really should be on the lookout for hypoactive delirium, just because you don't know which patients are going to be those that need a little extra help, whether it's stroke recovery or whatever else it could be.
And this only emphasizes the importance of continuous monitoring for delirium among hospitalized patients, particularly the elderly, regardless of the reason for hospitalization, because hospitals don't always make people better. For the listeners out there who went through med school and listened to Golyon's lectures for your board exams, you'll probably remember that guy refuses to go to the hospital if he ever gets sick. He knew patients would never come out the same. But that's not to say that you shouldn't go to the hospital if you get sick. If you're sick, go to the hospital. Just be mindful of delirium.
Certainly in vulnerable populations, so the elderly, it's important to look out for disturbances in sleep-wake cycles, disturbances in orientation, just having normal conversations with patients. Sometimes, people who are otherwise impaired can fudge their way along, but paying attention to just basic sort of conversational topics that are related to things going on, current events, things like that, can really go a long way in piquing your interest and being like, okay, is this person actually with it, or are they faking it, or am I not paying enough attention? Trying to do whatever brief things that you can to see how with it a person is can go a long way in identifying delirious states early.
Yeah, I think it's really easy to go about your morning rounds and seeing your patient who has a CHF exacerbation and going through your checklist of do they have pitting edema, how is their lung exam, are there any new abnormal heart sounds, but not actually having a normal conversation with the patient. And those little things that you do that are just that little extra bit, those can have an enormous impact on their care long term. And I think that all those things are very important to do.
Yeah, the other thing too is the thing to recognize with the patients who are kind of apathetic or, kind of disinterested is to be able to provide them additional resources or to provide them more intensive physical rehabilitation or physical occupational therapy, because they're going to be cognitively impaired and less able to engage in things that could eventually help them get better.
That's all we have on the program this week. Thank you so much for tuning into the show. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. We are supported in part by BillUp, which is a mobile app that you can use to optimize your outpatient billing and ensure that your efforts in the clinic result in the right insurance payment. With the app, and with a few clicks, you'll know if you can up your billing from a level 3 to a 4 or a 5. It's so simple and quick that it takes the thinking out of billing. BillUp, available on the App Store. Also, again, huge thanks to Dr. Ayyappan Venkatraman for joining me in this week's program. Dr. Venkatraman is also a musician, and you'll soon be able to get his first EP on iTunes. The album is called Zanzibar, and for more information, check out his website at ayyappanmusic.com. That's AYYAPPAN music.com. But music for this week's program was courtesy of Unheard Music Concepts, Kevin MacLeod, Lee Rosevere, and Steve Combs. If you're looking for additional information on what was covered today, you can always visualize what's being discussed by checking out the blog at brainwaves.me. I'm Jim Siegler, and I'll talk to you again soon.